My colleagues, good afternoon, everyone. Let's start. Dr. Nahum, are you ready?
Yes, Doctor. Good afternoon.
Yeah. Afternoon. I think less than 20 days, not 20 days, less than 14 days for the exam, correct?
Yes.
Yeah, my advice for all of you in these 14 days, keep calm as much as possible. The exam need a lot of luck, a lot of blood support, really. I mentioned before, two, two candidate of the same level of knowledge, one pass easily and one stumbled. It need a lot of God support, a lot of luck, a lot of uh, calm and stable nerves. I think more than 50% of the candidate who didn't pass Viva exactly, especially, they lose their nervous stability. Okay. And by the way, keep always telling yourself I positive sentences like it will pass, I will success, uh, like this, God will help me. Really, all of these positive sentences give very good energy and very good um, positive pushing for you. Okay, let's start. This patient has a chest pain. I think he is adult, about 26 or 30 years old. Go on.
Okay, so I'm presented with frontal radiograph of an adult, 26 years with chest pain. I can see that there are multiple ECG leads. The lungs appear clear, no focal lesion, no pleural effusion, no pneumothorax. The cardiac size is within normal limits. There are no enlarged hilar or mediastinal lymph nodes. The upper abdomen is unremarkable and the trachea is central. I would like to have a look through the bones. The ribs appear unremarkable, no fracture, shoulder joints are intact. The vertebral column shows an abnormality at the level of, I'm counting from below, and I think this is going to be about uh, about T10 level. There is malalignment of the vertebral column, and the end plates between these vertebrae appear indistinct and irregular. I would like to check for any surrounding opacity that might indicate a paravertebral collection.
Where?
There is, yes, there is no definite obscuration of the descending thoracic aorta to suggest any added
You
opacity
mentioned
at that
you men,
top
you
button.
mentioned you mentioned there are para-vertebral collection. Where?
Okay. I will request the control so you can detect my cursor. Okay.
Yes.
Okay. So this area is abnormal. There
What
is
else? What else?
malalignment. Okay.
What else?
And there is, yes, this is the descending thoracic aorta, and I think this is the right cardiac border. I'm looking for any added opacity. There is erosion, and there is some rounded opacities over here on the left side of the vertebral column. Looking, the pedicles are not visualized of the lower vertebra, and there is a slip to the left of the column. The rest of the vertebrae shows no similar lesion to suggest multiplicity, and the rest of the bone show no focal lesions. So I'm so much concerned about infectious or inflammatory process going over here. The patient is young. I'm not favoring malignancy. So I would like to correlate the lateral view with the patient history for any constitution symptoms and proceed for MRI to further characterize the abnormality, inquire about any neurological symptoms that might indicate port compression.
MRI,
So,
Dr. RCT.
okay, so this is the CT for the same patient, axial cuts, bone window. I would like to have a general look before commenting. So I think this is the last cut going up. There is abnormal increase soft tissue density in the paravertebral region, which is displacing the aorta anteriorly, surrounding the vertebral column on both sides. The density shows no calcification. It is homogeneous, displacing even the heart anterior and the esophagus as well. I would like to check for the, it is very, it is involving more than multiple vertebral levels. Yes, and there is destruction at this vertebra with multiple bony fragments, erosions, again denoted the malalignment, and the severe cord neural canal narrowing with intracanalicular bone fragments involving the lateral, the pedicles and the transverse processes as well. So this is
Mhm.
a destructive lesion. Uh, there
Mhm.
is bone sclerosis.
What's your
So
final diagnosis?
okay, so no other level of involvement. The patient is young, uh, very long segment. Can I take the soft tissue window or the lateral view to complete the assessment? Okay, so this is the sagittal. There is a loss intervertebral disc space, significant retrobulging. Any history of trauma for this patient?
Yes,
Right
he had
now,
history of trauma. He had history of
there is
trauma.
there is trauma.
Yes.
Okay. So this is a child's fracture. It is okay. It is dorsal level.
What's
It is
it?
not lumbar level. Okay, so it is a fracture involving the anterior and posterior elements. So this is a seatbelt fracture or the chance fracture. This is highly unstable. This is for urgent refer to the neurosurgical team for relief, immobilization, and further completion by CT. Yes, I would like to check the rest of the CT abdomen for retroperitoneal injuries that are highly associated with this type of fracture. The patient needs to be urgently referred and managed to decompress the core by MRI of the after stabilization.
Okay. Thank you so much. So this is a burst fracture or a chance fracture. What is the difference between both of them?
Chance fracture involves
Chance
the
fracture.
vertebral body and the posterior elements.
Okay.
It is due to the
But
seat
you,
belt on the
but
rear seat.
okay. But this is not the descending aorta. Why? This is See, this is the displacement of the lateral spinal line.
Yeah, there is
Okay.
double line. Yes.
Yeah. Okay. Lateral paraspinal line. Okay. Why? Um, Follow it. There are two double lines. Yes. This is
Yes.
line. This is line. One of them is the aorta, and the other one is the paravertebral collection, which lead to displacement of the left lateral paraspinal line. Very important. I don't know how could you detect this very non-obvious lesion and you forget this. Okay, anyway, you get something to proceed to CT or MRI. Look here, this is emergency. Why? Here at this level, there are acute compression of the cord, destruction of all of the three columns, unstable destruction of fracture called chance fracture with kyphotic or gibbous deformity, it needs urgent decompression. No way. Okay, this is one of the causes of coda equina syndrome. Okay, very important, my colleague, in any fracture to detect any retropulsion. To comment on the posterior arch, very important. Okay, so finally, the answer is lateral displacement of the left paraspinal line due to thoracic spine injury. Uh, I don't know the source of bleeder here because it is completely surrounding the aorta here, but the aorta is completely normal. No extravasation of contrast. One of the most important of paraspinal or prevertebral hematoma is the
Intercostal.
spine. Okay, maybe small bleeder here, small because it must be checked for any major vessel injury like the aorta. Here, if you look here, there are apparent arteries, correct?
Yes. Yes.
Aberrant, aberrant right subclavian artery. Thank you, Dr. Nam, so much.
Thank you
Next
so much.
candidate. Welcome.
Hello, Doctor.
Next can. Hello, welcome. 15-year-old male patient presented with neck pain.
Okay. I'm presented with Sagittal T2 MRI of the cervical spine.
Yes.
Go through the images first.
Do you want control?
I requested it.
Go on. Hmm. Go on.
Okay. Oh, it's working. Okay,
Yes.
I'm checking. There's focal expansion of the cervical cord with the there is a low T2 signal lesion in front of two, three, four, five, C6-7 vertebra, uh, intraspinal extramedullary region.
Where?
Uh, no, it's here. Can you see my mouse?
No, this is safe position.
Okay,
What
okay.
else? What else?
There's focal expansion of the cord with ill-defined T2 signal.
The
Uh,
the
I'd like.
cord. Don't worry about it. What else?
Okay. The 15-year-old. I'm checking the skull base. No evidence of herniation. No evidence of tonsillar. The adenoid is enlarged. It's non-significant. Look at the review areas at the edge of the film. Couldn't see any significant abnormality. Um, I'd like to review the T1 images to check for the bone marrow, if there are any bone marrow infiltrates or
No, this
any
is
other.
conclusive. Look here. Compare this side with this side. Could you find any discrepancy
Oh,
here? Yes.
there is expansion of of C12 and C23 neural foramina
Yes.
with the high T2 signal surrounding the both neural foramina, was widening of the neural
Okay.
foramen.
Okay.
My first thought will be some sort of neurofibromatosis, given the patient age, or any cause of the nerve sheath tumor. I'd like to get the coronal post-contrast slices to check better for the image. I would like also to image the whole spine to check if there are any other lesions in the whole spine and the brain. Check there are any other associations for the phacomatosis, NF1, neurofibromatosis type
Do
1.
you think, doctor, do you think sarcoidosis will cause all this eczema? Look
Uh,
again, please. Look, look. This is signal abnormality, not mass, not a true mass. It's just a signal abnormality. Okay. Where is the expansion? Do you expect? Which one?
uh,
Which one?
then here the neural form is expanded.
No, see, look here. This neural foramen is the normal neural foramen. But do you speak about here, this level?
Yeah, the cut after it's some sort of expanded, like
Where?
here.
No. Look down, please. What is this? What? Leave the mouse. What is this? Leave the mouse. What is this?
I
This
cannot see
one.
what
This
I
one.
cannot see. Uh, I
Leave
cannot
the
see.
mouse.
I'm,
Okay.
I,
Leave the mouse.
okay, okay. Yeah.
Look here. Is this normal or abnormal?
No, it's abnormal. It's a lesion in the neural foramen.
Okay. So what do you think about it?
Uh, the lesion in neuroforamen, I cannot see any genetic change in the disc. It could be a nerve sheath tumor,
Okay,
either
okay,
neurofibroma or schwannoma. I'd like to check
okay.
the other
But
images.
but my question before, do you think neurofibroma will cause this market edema here, soft
No,
tissue edema, compare with the other side? At
no,
least look here.
it's
See, there are something here, and there are market soft tissue edema. Okay, it may
okay.
be okay. It may be one of the differential diagnosis neurofibroma. But what else?
I'll get like this is it seems like an acute pathology because due to the marrow edema. I think of inflammatory causes, osteoarthritis, but the patient age is young for such pathology.
Yes.
I think of metastasis with metastatic deposit. Uh,
What
Another
else? The
uh,
patient is still young. Young.
maybe some sort of bony infection, osteoarthritis, bone infection extending to the facet joint and causing the edema surrounding uh, sur-
What else? What else?
uh, plastic inflammatory other metastatic deposit from a primary for this age could be sarcoma or
The patient
osteoma.
is 15-year-old and he has chronic cervical pains. Okay. And we have a lesion here. We don't know either it is centered on the posterior arch, okay, or from the foramen. It has all the possibility. Okay.
Okay.
So we must give as much as possible differential diagnosis. What
Mm.
other differential diagnosis?
I think of them, but it's a very rare condition. It's osteoma of the
What is your next step?
for perform a CT.
Okay. Go on.
Okay.
Go on.
I can see an it's a expansile lesion with the rings and arcs of calcifications seen
Yes. Yes.
uh, in the left affecting the left neural exit foramen, likely arising from the pedicle of the vertebra. It's likely a chondroid-based lesion. Can be a chondroma, differential chondrosarcoma. I'd refer the patient to the neurosurgery for removal and histopathology to relieve the pressure on the
What
cord.
other than neurosurgery? How
Uh,
could you hmm,
by
how could you
intervention
treat?
radiology.
Yes. What is it
It could
exactly the
be
name?
radio ablation. Can be done by radio ablation, but to be tricky
Okay.
due to it's very near the cord, so it has been done at an MDT to discuss the pros and cons because it's very near to the cervical cord. It has to be done in MDT, whether surgery or intervention radiology is better to assess this patient.
Okay. So our diagnosis is osteoblastoma. Okay. What is the difference between osteoblastoma and the osteotestioma?
Size less than 3 centimeter or more than 3 centimeter, I think. The size
Not
they both less
three, less. I think less.
less
This is
less
the 3 centimeter is the size, the benchmark between the nodule, pulmonary nodule, and the pulmonary mass. Okay.
1.5. It's
Yeah,
1.5.
one. Most, yeah, most of the most textbook mention 1.5 or 2, but it is not 3. Okay.
Yes, sorry, it's 1.5. I got mixed
Okay.
between.
No problem.
Yeah.
See here, it is completely within the pedicle. Okay.
Hmm.
Sure, it is very difficult in the MRI. My question for all of you, my colleagues, why we can really judge um at the source or the center of this lesion? I mean, why we can't judge either this lesion centered or originate from the pedicle or from the nerve itself by MRI. What is the cause? There are very important cause related to the nature of the MRI machine itself or MRI signal. Anyone know? Our candidate, do you know why?
Uh, it could be done
By
if
the way,
thin
it is
cuts.
out of it is no no no. It is out of RCR exam field. It is out the scope. By the way,
Both
Hmm.
are the same signal on T2.
No
It's very hard to differentiate between them.
no no. What else? Why we even which يعني, which sequence you try to search this one, you will not because it is hypo intense. No. Um, extensive edema. No. What else? It is something very important. You will be surprised, all of you. Really, you will be surprised about the fact that I will mention now. But
Yeah.
first, I wanted to listen from you. No, no. Excellent. Dr. Shuru, Dr. Shuruk, excellent, excellent, excellent. Our colleague, Dr. Shuru, exactly give us the proper answer. Do you expect, my colleague, that the MRI has low spatial resolution than the CT overall? So, so in many of the abdominal, not in many, in all the abdominal tumor, it is better to detect the invasion to the vessels or to the tubular structure by CT, not by MRI. Very surprising fact, I know, for all of you. Why? Because the CT has better resolution or spatial resolution. What I mean by spatial resolution or resolution? The ability to differentiate the very fine details. Very simple. Here, hello?
Hello. Yeah.
My voice clear? Here,
Yes.
why we can't detect clearly this lesion either originate from the nerve or from the bone? Because if you, whatever you zoom the image, you will not pick up the very fine details because it's related to the MRI nature itself. Why? Because MRI sequences can show you as much as the CT, the very fine and small details due to its low spatial resolution. Okay,
Yeah.
so the application of this information in many of the tumor in the abdomen, especially. At first, I listened this fact. It was through one conference about the abdomen. The best to detect the invasion for the vessels by CT, especially in pancreatic tumors. So finally, we are searching here. If at least you look here, you detect that there are discrepancy between this site and this site. Doctor, there are edema at this site. Okay, soft tissue edema, and I could detect a low signal lesion here, centered at the foramen. Okay, but actually here it is between this foramen and this foramen. But at least if you told like this, the examiner will accept the excuse of low spatial resolution. Doctor, I'm worried about this lesion. It looks like intra intraspinal, but it looks like also extracecal, and it is sclerotic in all sequences. Look here, even see here, it is sclerotic. So, doctor, I'm a doubt about calcified lesion or a bony lesion or something else. Peripheral nervous tumor. I want to exclude or to do CT. This is the CT. Look here, is exactly centered at the pedicle. Our colleague mentioned it has arcs, and I agree with him, by the way. It has arches or it has central calcification. It may be some chondroid lesion. Okay, we didn't have the exact pathology, but I think it is not a clear or frank arches
Yeah.
and rings of calcification. It looks like chunky or big pieces of macro calcification. Anyway, at least we exclude the nerve sheath tumors and the meningioma. We are now talking about this bony lesion. Doctor, could you see here this is sclerosis?
Yeah, the sclerosis adds more to the to the osteoblastoma. It's the
Yeah,
edema
yeah,
more than
yeah.
the
This is
chondroid
very
lesion.
important. Thank you. Really, really thank you. The sclerosis is favored more the osteoid lesion more than chondroid lesion. I think because the why, doctors? Do you remember why?
It causes bony irritation. It's relieved
Yeah,
by non-steroidal, I think, non-steroidal
prostaglandins. I think by
prostaglandin
prostaglandins, something like this. Okay. The most important line of treatment here, I think RF.
or radioablation.
RF. Because why? Because it is very overall very simple operation in comparison with the neurosurgical open surgery. Whatever, and I think, see, doctor, the 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 interventional doctor can radiologist can come from here. Okay, it is touching the cord from here, but he comes laterally. See here.
Yeah,
See, I will show something. Look here.
yeah,
Look.
yeah,
He even can use this plane. This
yeah.
one.
Posterior
Why?
approach.
Yeah, posterior average. Why? Any one of us, if you work before any CT guided technique, you choose the most applicable and the most safest way. You can come from here, and you can direct the needle to be far from the cord as much as possible. I'm not expert in this type, but I think it is possible to do this intervention RF radio frequency ablation. Beside the role of prostaglandin. Okay. Thank you, doctor, so much. Uh,
Thank you, doctor. Thanks a
nice
lot.
case. Welcome. Next candidate.
السلام عليكم.
Salam. Again, this case was osteoblastoma. Okay. Osteoblastoma is bigger than osteoma. See here, more than 2 cm. Very important. Very important, my colleague, to know the benchmark. But in pulmonary nodules, the 3 cm benchmark, the 3 centimeter benchmark, it is related to the pulmonary nodule and the mass. Okay. I will give you some tip
Okay.
to be sure from your answer. The lung is bigger, so you need 3M. But the bone is much smaller than the lung. So the benchmark between osteoma and osteoblastoma is 2 cm. 35-year-old female patient presented with pelvic pain. Go on. You can request control, doctors. Go on. Go on.
This is axial
Yeah.
axial MRI study at
Yes.
T1 phase of a patient of a 35-year-old female patient.
Yes.
Okay, I can
Yeah.
see that there is no abnormalities at both psoas muscles as well as the iliac vessels. I can see 2 cystic lesions, one on each side of the pelvis, as well as a large hypointense lesion here,
Yes.
right located above the uterus. I would like to revise the sagittal cuts at T2 to localize the lesion and its relation to the
No sagittal cut.
uterus.
No sagittal cut.
No
What
sagittal
what
cuts.
is your next sequence? Do you want the next sequence?
The next sequence is axial T2 cut.
See, doctor, again. What did you find here? What is this? What is it?
I found two
Yeah.
cystic lesion,
1 second.
one on
This is
each
T2
side.
or T1?
This is T1.
Okay, so you
I
find what? What did you find?
I found a lesion right here and another one right here
Mm-hmm.
and a hypointense lesion right here. So I have three elements I would like to revise at other cuts to localize and better describe.
What is your differential diagnosis of high T1 pelvic
My
female lesions?
my differential diagnosis of high T1 pelvic female lesion is firstly fat-containing lesion, dermoid lesion specifically, and
What else?
blood-containing lesion.
So how to differentiate between them?
The fat suppressed T1 study would
So
differentiate them from each
your
other.
next sequence is T1 fat set. Go on.
So this is a T1 fat set study where the described lesions are not suppressed, so they are a blood-containing lesions. Considering being hemorrhagic or endometriomas, I will uh, firstly search for other.
How to differentiate between hemorrhagic cyst and endometrium?
I would like to ask if there is any history of cesarean sections
No, I'm talking from MRI aspect of view.
from MRI aspect of view. The endometrioma show a T2 shading effect because
This is
of
the T2.
the
Okay, this is the
different
T2.
ages.
So you must ask me, doctor. I want see, doctor. The exam is like step by step. I give you T1
Mhm.
without fat set because I want you to ask me for T1 fat set. Then I want
The
you
T2.
to give her T2. Okay.
Okay.
One of the common mistake of most of our group are doing till now, we are telling or telling the examiner, I will do like this. The examiner wanted to from you to ask him, doctor, give me T2. Okay, why to
Okay.
detect or to exclude T2 shedding like this. Okay,
Okay.
okay. What do you
Okay.
think here?
I can see at the lesion at the right side, I can see T2 shading,
What is the T2 shedding?
differential intensity of the lesions. This
Mm.
seems to appear here at the right side where there is
Differential what again?
gradual
Differential what?
difference in intensity.
In intensity. Okay, okay. Go on.
So we have here a differential intensity returning from the lesion at the right side,
Mhm.
and there is the lesion at the left side has the same intensity. So
So what's your
I think
diagnosis here? Diagnosis?
my diagnosis is endometriomas of different
Okay,
ages.
okay, okay. What else? Look
Okay,
here, I
I
will help
can
you. What do you think about this, like this level here specifically?
I think that there is a level here,
Mm.
a
Mm.
level here with the upper part of high intensity resembling the intensity of the fat.
What
So
else?
this
What else?
I can also see that the uterine endometrium is thickened. I would like to measure that,
Don't
and
worry about it. Don't worry about
I
it.
can see that the myometrium is thickened and of high intensity.
What happened
So
here? What happened here?
uh, I think This may be
Would you describe the relation between the rectum, the right and the left ovary and the uterus? What happened here for this fourth structure here?
the region is seen insinuating behind the rectum, and the rectum is located between the two lesions. So
What is the name of this sign? Okay.
I don't know.
Okay, so what does it mean? Approximation of both ovaries and the rectum and even the cervix. You
I don't know.
correctly diagnosed there are endometrioma. Okay. One
Mm.
of the more severe endometrioma and one of the complication. This one. What does it mean or what is this?
Invading of the rectum and sigmoid walls,
See,
or
I will help you. There are some fibrosis occur here which make this cicatricial clover leaf sign. Why? What is the cause? How many type of endometriomas do you know?
I can't remember.
There are ovarian endometriomas, okay? And what else?
Okay.
What else? Deep pelvic endometriomas, correct?
Mm-hmm. Oh,
This is deep pelvic endometrioma. How good? Thank you, doctor. What happened
thank you,
here?
Dr.
There are fibrosis here. Look here. This is, you can call this one a casing ovarian sign. Look here. Look here.
Mm-hmm.
If you look at both ovary, see, they really kissing each other. They
Mm-hmm.
adherent. Why? Due to deep endometriosis, which cause fibrosis. And if you look at the axilla here, 22, there are cicatricial approximation or adherence between. Look the rectum. Look the rectum. This is abnormal. How could the rectum to be insinuated between both ovary and very near from the uterus? And if you look here, this abnormal signal is very specific for deep pelvic endometrioma. This ligament, this is the uterosacral ligament. This is the first sign, my colleague, of deep infiltrating pelvic endometrioma, thickening of any side of the uterosacral ligament. It is
Mm-hmm.
attached to the cervix of the uterus or something called specifically, we will give you the name, torus uternus, this one. Torus uternus, this one. This dark signal with the ligament, this one ligament is very, very specific for deep infiltrating endometrioma. Besides the casing, K-I-S-S, casing ovaries besides the clover leaf side. So the answer was, one second, the answer was, well, no, not working. Anyway, this is deep infiltrating pelvic and ovarian endometriomas. Okay, my colleagues. Again,
Thank
this
you,
one,
Dr.
ovarian endometriomas with deep pelvic endometriomas. Doctor, you did very well, but I think you are afraid a little bit. You have all the knowledge, by the way, and you know the next sequence. Don't be afraid. Uh, uh, Most of you has better information more than the examiners.
Okay.
Okay, so
Thank you, Dr.
don't be frightened from the exam. Okay, thank you. Next
Okay.
candidate, welcome, welcome. Uh, Next candidate,
Yes, sir, I'm here, sir.
welcome. Doctor, request control.
Thank you. Yes, sir.
Request control, please.
Done, sir.
Request control. Yeah, go on.
Yes, sir. Yes, sir.
Go on. This patient presented with headache.
First, I'll go through the all images. The CT scan brain in axial section,
Yes.
non-contrast CT. Okay, I will see till the last section of the CT brain. Okay. So first, I will concentrate on CT brain. I saw a few calcified nodules at the subependymal region on the ventricular wall on left side. I will go back to that. Yeah, near the
Yes.
caudate nucleus on left side,
Yeah. Yeah.
and
What
also
happened?
in
Tell me.
these first things I'm thinking of subependymal nodules. This can be a case of tuberous sclerosis.
Okay.
Um, and any periventricular calcifications, in congenital periventricular calcification. However, first I'm thinking of tuberous sclerosis. There is no evidence of any dilated ventricles in this. No evidence of any other lesion near the foramen Monroe or any other
Yes.
location.
Yes.
Um, the periventricular, the subcortical white matter appears to be normal. No evidence of any calcification there in the rest of the brain. Uh,
Yes.
but I would like to. So I'm thinking of tuberous sclerosis in this case. I would like to rule out the other manifestations of tuberous sclerosis. I would like to do
What's
MRI
your next?
brain.
What's
I would
your
like
next step, Habib?
MRI brain, sir. I would like to do MRI brain.
Okay. MRI brain. Yes. Okay. Go on. Hey,
This T2 sequence.
my colleague.
Yes, sir.
One second.
Yes.
1 second. In very obvious case like this, uh, I think when the examiner gives you just calcification, subependymal calcification like this, and the rest
Yes,
of
sir.
the examination looks like normal, don't waste more than 30 seconds. 30 seconds
Yes, sir.
scrolling
Mm-hmm.
the image, and 30 seconds describing and telling the exclusion, and immediately give me MRI. Why?
Yes, sir.
He-
Mm-hmm.
the technique of the exam depend on startup, something startup. Like the first case with Dr. Nagam. I gave her something startup. Okay. I
Mm-hmm.
want to just
Yes, sir.
from here to pick up the initial abnormality. If she didn't pick up this initial abnormality, she will lose the case completely. But
Yes.
the exam didn't contain anything else. I will tell you one mistake. I was given one X-ray, and
Yes.
I didn't get the subtle or the primary finding. Okay, the
Okay, sir.
examiner
Mm-hmm.
immediately shift to the other case. Okay,
Mm-hmm.
when you it was very simple issue, by the way. It was very
Mm-hmm.
simple issue. Okay,
Mm-hmm. Okay, sir.
why? Because all of these examiner are human being, and they start, I think, like from 9 o'clock till 4 5 o'clock. In my last
Mm-hmm.
Viva, they delayed us about 20 minutes because the examiners were exhausted.
Mm-hmm.
It was in the mid of the day, by the way. It was at 12 p.m. They told us they
Mm-hmm.
wanted to take a rest and drink something. See, so they are human beings. They won't assess you as much as possible, as less time as possible. By the way,
Yes.
why I'm telling like this? because he is a human and you are a human. If he become happy from you, really he will pass you. Sure, there are some human factor in the exam. We can't deny that. Go on.
Yes. Okay.
On.
So this T2 sequence, MRI brain, axial sections.
Yes.
My CT findings confirmed. There are T2 hypointense subepineal nodules on left side. Oh,
Uh-huh.
okay. There is some lag. Yes, fine.
Mm.
Yeah, on left side, subepineal nodules. Right side also, I can make out a small, tiny hypointense nodule on right side. I'm now looking for any cortical tubers which appears as hyperintense signals in the cortical white matter. I can see in the left temporal lobe in posterior aspect.
Yes.
Um, yeah, on left side, and the rest of the brain parenchyma doesn't reveal any obvious
Which
hyperintense.
which which group of diseases does this tuberous sclerosis related?
Phygomatosis.
What do you mean by psychomatosis?
Phygomatosis. These are um, s-
Mm. What do you mean by that?
mm,
Psychomatosis. You
yes,
you find here some brain or CNS abnormality, okay?
yes, sir. Mhm.
And what else? What else in psychomatosis we find?
So they'll having some hematomas in brain,
Where? Okay,
uh,
and where else?
skin, adenoma sebaceum in this patient, skin, uh,
Yes, so it is neurocutaneous,
neurocutaneous syndromes.
hammer,
Yes,
yeah,
yes,
hamartomatous syndromes. Okay,
yes, sir.
could you tell me other common psychomatosis?
Sturge-Weber syndrome,
What else?
Sturge-Weber syndrome, neurofibromatosis type 1.
Okay, what else?
These three,
So you mentioned
neurofibromatosis.
tuberous sclerosis, Weber syndrome, neurofibromatosis, and the basal nevi syndrome. Okay, at least four, more than enough. So,
Yes.
uh, what is your next step?
I would like. This is in this 3D brain, MRI brain. I can see suborbital nodules and cortical tubers. However, there are no evidence of any complications like suborbital giant cell astrocytoma or no evidence of any hydrocephalus. Further, I would like to. I would like to examine the CT chest as well, chest as abdomen, as these patients would like to have cystic lung disease in lung, and as well as new complication as pneumothorax, and in
Yes,
abdomen they will have this angiomyolipomas. Again, they are also prone for rupture. So I would like to do CT chest and ultrasound of abdomen for further
yes.
investigate to this patient. Then I will inform the findings to the referring physician, and also do the genetic counseling of the patient and his family members.
Okay. Uh, what is the emergency signs in patient of psychomatosis? Give me two, three signs or TC critical finding. Not only in
Mm,
brain.
uh, brain hydrocephalus, chest
Okay,
pneumothorax,
okay, excellent.
abdomen rupture angiomyolipoma with hemorrhage, Wondlick
Yes.
syndrome.
Thank you, doctor. Like this, the discussion in the Viva exam. Sometimes the examiner are asking you unusual, but he has right to ask you at least about the critical signs. So our colleague, the answer was tuberous sclerosis. Beside what you mentioned, you must also do family screening, do chromosomal anomaly for this patient. But this patient is 30-year-old, and
Yes,
this is a very misleading history. Okay,
yes,
take care, my
yes.
colleague. Take care.
Thank you,
Okay,
sir. Thank you.
welcome. Next candidate. Sorry.
Yes, sir, I'm here. I'm sorry, I had some phone problem. I can't take the
No
control.
problem. No problem. This patient is 30-year-old presented with seizures. 13 years old. 13 years old presented with seizures.
Okay, so MRI axial images of the T1 sequence, in
Okay.
which the patient 13-year-old presented with seizures. I can see a hyperintense signal abnormality area involving the right cerebral hemisphere. I need to look at right here. Okay, in the right inferior frontal gyrus rectus location, the inferior right frontal lobe, I can see an
Okay.
hyperintense
Uh,
signal
yes.
abnormality area. I would like to evaluate it on the other sequences on the SWI to look for its signal characteristics.
Yes. What do you want?
It's as the I would like to see it on the WI and SWI sequence as well to see if there is any hemorrhage or diffusion restriction.
Mm-hmm.
So it was in the right. Can I
Good.
see the ADC images, please?
1 second. It was in the right. I think no need for EDC. Did you find any
Okay.
abnormality here?
No, it
Good.
is a low signal, so yes, there is no need.
So why you need the EDC? No need. Huh? What else?
This
Take this one.
reflex post
Tell me.
contrast. Let me see. Yes. So this does not show any significant post contrast enhancement. It is hypointense on T1.
Mm-hmm.
Um, can I see the SWI to see if there's any signal dropout to see for if it's a hemorrhage?
Yes.
It uh,
Huh.
the area does appear to have some. Okay, there
Come.
is no convincing signal dropout. This is not hemorrhage. So
Okay.
I would like to see the paranasal sinuses and the dural sinuses to because I'm thinking that this is focal increased signal in the right inferior frontal lobe, and it could be secondary to cerebritis, or it could be secondary to secondary infection. My other differential would be dural sinus thrombosis, for which I would like to evaluate the sinuses on the post-contrast sequences, and I would like to see the paranasal sinuses on
Doctor,
the T2
do you
images.
remember the history? Do you remember the history?
Yes, seizures, focal seizures.
Did you ask me, doctor, is there are any fever?
No, I did
Ask
not.
me, please.
Uh,
Ask.
is is there any history of fever?
No fever.
Okay, there is no
And
history of
see,
fever.
another issue here. Do you think, doctors, do you think if this abscess or infection, it will be polite and the kind pathology like this without any edema? There are no any white matter edema. No,
Absolutely no
nothing.
edema.
No any mass effect. What does it mean for you?
So it is a focal abnormality without any edema. This is 13-year-old with seizure, no enhancement. So epileptic focus. I would correlate if there is any history of trauma.
Brain
It
trauma.
could be secondary to
Where is
contusion.
the tumor itself or the lesion itself? Look here.
This
Where
is in
is
the
exactly?
brain parenchyma in the
Yes.
inferior frontal lobe.
Yeah, yes. Where? Cortex or subcortical?
Yes, it is subcortical.
Okay. What does it mean? Subcortical? Are you sure? Look here. This is the cortex.
Cortical based. It is cortical based.
So, what is the shape of this patient? Of this lesion? See, I will help you.
It appears to be bilobed. It has peripherally
See,
hyperintense.
what is
Centrally,
the
it
name
shows
of
a
this sign? What is the name of this
bubbly
sign?
appearance. Yes, it
What
is
does
a
it mean for you?
uh, uh, peanut. Peanut. Sorry, I'm sorry. this embryoplastic neuroepithelial tumor is my top differential for this. This is a bubbly cystic multiloculated type appearance of lesion and hyperintense on T2. And considering there is no enhancement, no diffusion restriction, this is a benign appearing primary CNS tumor. So my top differential
So I
would be
told you
uh,
it show no any contrast uptake. What's your
yes.
diagnosis? Cortical, breve, frontal lobe, causing seizure. Bubbly appearance. What is your answer? Your diagnosis?
This embryoplastic neuroepithelial tumor, DNET.
Okay. Thank you so much. Take care, my colleague, before running in any pathway. Make sure is this infective or tumoral? Why? I start with giving him very easy, really. Uh, I didn't give our candidate T1. Give him this one. So there are lesion here without edema or massive effect. Okay? And this is cortical. When you are repeating the finding in your mind will remember you or like ChatGPT really, will form an opinion when you are talking with the examiner. Sometimes you are describing. I think I told you this his story before. Uh, uh, in my MD in Egypt, the examiner gave me very atypical case. This is the worst case that I saw in my life. Very, very aggressive lesion in the neck, infiltrating everything in the skull base and the orb, everything. And I started to describe to 7 minutes because it caused a huge disaster for the skull base. And if finally, I was about to tell him my diagnosis is aggressive, like malignant tumor like this. And then I saw signal drop, two pieces of flip. I told in my own mind, fly plus high T2 lesion and the enhancement. I told the examiner it may be vascular or lesion, vascular abnormality, hemangioma, like this. So when you are repeated or you are telling the examiner, your mind are also trying to form a diagnosis. Okay? Okay, doctor?
Yes, absolutely.
So here you are describing, so you must mention it is cortical, no edema, no mass effect, no enhancement, no restriction. All of this criteria only be found, sorry, in DNUT. This, sorry. Could you see my screen, my colleagues? Hello?
Sorry, we cannot see the screen, just the profile picture.
1 second. Okay. 1 second. It was a DNUT. What do you mean by DNUT? These embryoplastic neuroepithelial tumors. It is a peripheral cortical based lesions. Very common to be so public, very common to cause seizures. Okay.
Okay.
Next candidate, welcome. Next candidate.
Good evening, sir.
Good evening, doctor. This is 12-year-old male patient presented with central hypothyroidism.
Okay,
Go on.
I'm presented with the sagittal elevated sequence of MRI brain T1 images. I'm scrolling through the diagnostic images before commenting of my findings. Sir, can you scroll for me? I
I'm
think
scrolling. I'm scrolling for you.
Okay.
Then,
So, I'm just checking the any carry malformation for this child, and there is The brain stem looks normal for me, and the corpus callosum is unremarkable. There is no abnormal signal intensity in this T1 weighted sequence. I would like to see other sequences as well
Are you sure?
to.
Are you sure? Yes, again. There are no any abnormal signal here. Hello?
Yes, the corpus callosum looks hyper intense. Otherwise, I couldn't appreciate well any abnormal signal intensity in this sequence.
Here. What do you think? Do you
I'm
find
presented
any
again with
abnormal?
this. The pituitary gland appears unremarkable. There's the dorsum sella is unremarkable. There's does not show any abnormal signal, and
Okay, look here, what happening? I mean,
there is abnormal signal intensity is noted in the this uh, thalami and
mhm,
mammillary bodies and tactile plate.
okay.
And there is some
Look
also
here,
abnormal signal intensity in the.
what happened?
Yes, there are lobulated lesions are seen in the at the tactile at the region of the this suprasellar region, as well as in the place of this third ventricle above the third ventricle. Sorry, behind the third ventricle, above the fourth ventricle. This looks abnormal to me, and I would like to see other sequences, axial and as well as coronal, uh, and with post contrast and DWI images.
What's your provisional diagnosis here? And this is post contrast, doctor, by the way.
Okay, doctor. This most likely arising from the pineal gland lesion or this the location is somewhat is like because of this child and the age is corresponding to this like germinoma or something. Um,
Mhm. Yes.
and This is another the supracellular lesion also there, so it is, but I couldn't appreciate any orbital lesion. So otherwise I would think about this trilateral retinoblastoma.
Okay.
Uh,
Trilateral retinoblastoma. Okay. But see here, trilateral retinoblastoma means bilateral retinoblastoma plus benyloblastoma, as I know. But here,
Yes.
when you find supracellular and pineal lesion, we are talking about almost germinoma. How could you differentiate germinoma from other pineal lesions?
Sir, actually, germinoma is having calcification centrally, and this pineoblastoma has exploded calcification. So
What is the
this
name? What is the name of this calcification?
this
What is the name of calcification which occur in germinoma?
machinery oil calcification,
No,
like
no, 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 no.
this.
Machinery oil is something, another
Yeah,
thing related
yeah,
to
craniopharyngioma. Yeah.
supracellular
Yes, yes,
craniopharyngioma.
yes.
Uh-huh. Mhm. Okay.
Yeah.
But what is the name of calcification in germinoma, and what is the name of calcification of penocytoma?
Neocytoma. Sir, I'm sorry, I couldn't recall the exact name.
Okay.
Can
Where the calcification occurs of the germinoma, and where is of the penocytoma?
So in germinoma, this usually in the central location. Yani,
So
any any peer.
it is
Yes.
engulfed. Engulfed.
Engulf. Yes. Yes, sir.
Yeah.
Engulf. Yes.
But but in the pinocytoma or biennial parenchymal tumors, it is preferred, excluded, called excluded. So finally, bifocal germinoma. Bifocal germinoma. What do you want to exclude in case of germinoma? Or what is your next examination?
I would like to see this child chest, especially to see any germ cell tumor related to this, any in the mediastinal
Okay, what
masses.
else? What else? What is the
Uh,
common
any
complication of germinoma?
any drop
Yes,
mats
drop
in the spine
metastasis.
neural axis. Yeah.
Yes, so drop metastasis. Drop metastasis is very common in germinoma. Okay, and in what else? Tell me two other tumors commonly associated with drop metastasis.
Ependymoma and this medulloblastoma.
Glioblastoma, yes, germinoma,
Epend
and
Ependymoma.
germinoma. Very important, my colleague. In routine work, really whole spinal neural axis MRI must be done. Okay, thank you, doctor, so much. The
Thank you, sir.
answer
Thank you.
is supracellular and biennial germinal. Thank you so much. Next candidate. Next candidate.
Yes, sir. Assalamu alaikum.
Doctor, this patient presented with shoulder pains. Go on.
Should I request control, sir?
Yes, sure.
Okay. It's requested. Okay, this is an adult patient presented with
Yes, go on.
shoulder pain.
Mm.
Shoulder pain. This is coronal view of fluid sensitive ones.
Yes.
That I cannot. Yes. Okay, I will just scroll down from anterior to posterior ones to have an idea.
Yes.
Yes, so it's not scrolling. Okay.
Yes, scroll for
Okay,
you.
so there is a bit delay actually. Okay, so there is a high signal intensity area seen along the inferior glenoid region, and
Yes.
yes, can I scroll bit? I'm also so no significant joint effusion is seen. There are areas of a slight depression and sclerosis along the lateral aspect of the humeral head. The muscles, I cannot appreciate any signal abnormality in the muscles of the rotator cuff or in the deltoid. Yes, bone edema is appreciated in the proximal humerus. The
Where? This one?
yes, sir. Yes, sir.
No. No, see, it is intermediate signal in
Oh, okay. Yeah. Okay, it's
in
fine.
all sequences. What does it mean? See here. What does it mean for you? This is bone marrow, residual red bone marrow. Residual
Yes, that's fine.
red bone marrow is intermediate in all sequences. Okay.
Yes.
What else? Yeah, go on.
Yeah, I'm looking at the labrum, the superior inferior labrum. They seems to be there is some along the inferior aspect. I see there is some streak of high signal intensity, and there is some avulsion of the inferior labrum. Yes, and high signal intensity is also appreciated. This suggests an inferior labral tear.
Yes.
And I would also like to look at the other orthogonal views, if available, to see the humeral head. Again, this could, is there any history of trauma? This could
Yes.
represent an
There are trauma.
this could represent labral tear Benkart-Leon, and this depression along the lateral aspect of the humeral head could suggest a heel sac deformity or heel
Yes.
sac defect. This could be related to the anterior shoulder dislocation. However, on this provided image, there is no dislocation, but these injuries, they represent a trauma to the shoulder. There is no significant joint effusion. I would also, in my routine practice, I would also look at the plain film of the shoulder if available, just to confirm a finding on the plain films.
Did you find anything here?
Yes.
What?
There is a, it is a fat set image, fluid center. I can see there is lobulated kind of high signal intensity as similar along the inferior glenoid as well as along the medial aspect of the proximal humeral shaft. The linear area with low and high signal.
Yes.
Can I have
What is this? What is the name of this structure?
this is medial glenohumeral ligament.
No, inferior
Inferior
glenohumeral.
glenohumeral ligament.
How
Yeah,
many
inferior glenohumeral.
how many limbs have? It has 3 limbs. Okay, posterior limb. Okay, and then middle or inferior, middle, and then anterior. Look at the anterior torn. Okay.
Yes, anterior is torn.
So what's your final diagnosis? You told me there are heel sac. What else? Did you find anything in the anterior labrum? Yes or no?
Yes.
Here.
Yes.
What is this? Leprosy. What is the name of anterior leprosy?
I think there is mild avulsion and but periosteum is intact. Periosteum of the bone is intact. The labrum is
This is
partially torn.
okay. This is maybe pancreas, or at least we have heel sac tumors. Heel sac injury or fracture here. Okay, and
Yes,
anterior inferior labrum tear. Okay, how
Bengart.
to see
Yes,
heel sac? Uh, where exactly we can diagnose or be sure that is heel sac lesion or heel sac fracture? Where, at which level? There are
I
very
think at
characteristic
the
levels.
yeah at the coracoid level.
Yeah. Where, at the
I mean,
cricoid or above the cricoid?
above the coracoid is, I
Above,
think, it's
above.
normally there defect, and below the coracoid, I think,
No, the
at or
opposite. No, the opposite. The opposite.
opposite.
Below,
Okay,
yeah. Below the cricoid, this one is normal. Okay, but
okay.
here, see,
Above the coracoid.
yeah, at and above, this is a fracture. I see, we are above.
Mm.
We are above here. Okay. So finally, our diagnosis is Panker and heel sac injury. If this is Alapsa and you told the examiner this is Panker, it will not be a big deal. Why? Because in transverse or transform the Alapsa to Pankert to treat it. Okay, my colleagues. Thank you so much for all of you. Thanks for our coordinator.
Thank you, sir.